Hi, a very good afternoon and welcome to the afternoon sessions of our research E-Carnival Day 2. So in today's morning session just now, we learned about the rebound programs where a very comprehensive research team actually looked into the early diagnosis and management of breast cancers, as well as the survivorship care of these patients, not just from the clinical and biomed aspect, but also from legal, cultural, as well as public education aspect. And now, during these afternoon sessions, we will be addressing two areas which were previously neglected in public health. Today, we are very honored to have Associate Prof. Dr. Daliana from the Department of Social and Preventive Medicine to share her insights on young people's mental health status, particularly during these pandemic periods. So just a little housekeeping before we get started. If you have any questions or thoughts during the talk, please feel free to type it in to the Q&A box in your Zoom sessions. And a bit of backgrounds of Associate Prof. Dr. Daliana. She earned her medical degree from the University of Adelaide. Upon graduation, she joined the Ministry of Health Malaysia and served in various organizations, including the Muka Division's Health Office and Ulu Langat District Health Office. Prof. Daliana is currently an associate professor and a public health medicine specialist in the Department of Social and Preventive Medicine, FOM, University Malaya. She has a special interest in adolescents' health. More specifically, her work aims to address the 5 areas, namely the sexual and reproductive health, mental health, nutritional health, physical activity, and high-risk behavior. And now, let us welcome our first speakers of today's afternoon session, Prof. Daliana. The floor is yours, Prof.
Thank you very much, Dr. O, for that kind presentation. Can I just check if you can hear me?
Yes, loud and clear.
Okay, I'll share my screen.
Yes, please.
Okay, can I just check if you can see my slides? And
yes, in presentation slide.
It's in presentation. All right.
Okay.
Okay, thank you very much, Dr. O. Okay, hi and good afternoon. My name is Dr. Daliana binti Farid. I'm from the Department of Social and Preventive Medicine. First of all, I'd like to thank the organizers for inviting me to speak at the Research E-Carnival today. In this presentation, I'll be talking about our ToHeal mobile application, which has been used to assess young people's mental health status, and also how we've actually used this app during the COVID-19 pandemic in a community program. Okay, just before that, just for your information, young people has been defined by the WHO as those who are aged between 10 to 24 years old. However, this particular app, the ToHeal app, has been used only for those who are aged 18 and above. Okay, so before I proceed to the content of this presentation, I would like to acknowledge my program leader, Professor Dr. Mazna Dahlui, and also my project team members who are from various faculties, namely Faculty of Medicine, Faculty of Computer Science, and also Faculty of Arts and Social Sciences. I would like to also acknowledge our funders, UMRG, University Malaya Research Grants, specifically Equitable Society Research Cluster, as well as WHO Western Pacific Region Office, as well as APAC. So this will be the content of my presentation, of which I will touch a bit on the prevalence of mental health problems in Malaysia, and also the mental health services in our country. Then I will talk a bit on the mental health application and how we've actually developed this ToHeal mobile application and evaluated it, and also shared our experience and how we've used this app in a community-based mental health promotion among adults in a low-income community. And later I will conclude it with some of the strengths of this application and also some future direction. Okay, as an introduction, globally 10 to 20% of young people experience mental disorders, and this has been reported as greater among youth aged 16 to 24 years old. And in Malaysia, it has been found that the prevalence of mental health problems among individuals aged 16 and above have increased approximately threefold from 1996 to 2015, as you can see from the figure. In 2015, the National Health and Morbidity Survey, or NHMS, have reported that the prevalence was actually highest among youth who were aged 16 and 19. Sorry, the prevalence of those having mental health problems. In 2017, the National Health Survey, which focused on young people aged 13 to 17, has reported that the most prevalent mental disorder was anxiety at close to 40%, followed by depression at 18%. And the most recent NHMS, it was reported that close to 10% of 10 to 15-year-old adolescents have mental health problems. I think most people are aware that in Malaysia, the Ministry of Health is the main organization responsible for our health and also mental health services. In 2002, the MOH have actually started our mental health promotion, early detection, and also giving treatment of common mental disorders in our primary health centers or in clinic kesihatan or health clinics. And in the primary health centers or PHCs, they have focused more on mental health screening among adolescents, and they have actually collaborated with our school health team and do some screening as well in the school setting, and as well as adolescents who attend the clinic kesihatan or health clinics. Apart from that, I think the most recent program that has been carried out by the Ministry of Health is the Let's Talk Healthy Mind program, which aims to boost awareness among our community in terms of mental health, and also to increase the understanding or improve the mental health literacy of our community, and also at the same time to overcome the stigma. Okay, so apart from the Ministry of Health, it also collaborates with the Ministry of Education to produce a program called the Healthy Mind Program. So in this program, it aims to cultivate healthy minds among the young people. And what it does, it actually screens for mental health status and also risk factors among the school students. So this program is mainly available in schools. And for those who are identified to have depression or also anxiety, they'll be asked to seek help from the counselor, and if needed, they will also be referred to healthcare providers. Okay, so another program that was initiated by the National Population and Family Development Board Malaysia, or PPKN, under the Ministry of Women, Family and Community in 2005 is the Cafe at Teen Adolescent Center. So this center actually aims to improve the physical and mental health and social well-being of young people aged between 13 and 24 years old. So this program or center actually provides health services, counseling services, and also educational activities for our young people. And they can actually come to the center, get together, make new friends, and seek each other's help, and also discuss about whatever issues that they have. So another this is one app that has been produced again by LPBKN called My Cafe Teen app, which actually help teens to express themselves and also consult with doctors and counselors if they have any problems. So some of the things that are being featured in this app is Teen Bus, Teen Chat, Teen Info, Sahabat, Cafe Location. So they in this app they are able to to talk with other people, create conversations, and also get information about a lot of things, mainly for young people. Okay, so apart from our government, apart from services which are provided by our government, we also have a lot of non-governmental organizations who are actively involved in providing mental health services in our country. So some of it are like Malaysian Mental Health Association, Malaysian Youth Mental Health Initiative, and also Mental Illness Awareness and Support Association. So like MIASA, for instance, it is an organization that is set up by a patient for patients, and it actually, the aim or the mission is to create awareness, improve the mental health literacy of our community, try to overcome the stigma, which is very much related to mental health problem. Okay, so since the COVID-19 pandemic started, there's a lot of online psychosocial support that is also provided by various ministries. So some of it we have like Talian Sokongan Psychosocial or Psychosocial Hotline for COVID-19. And also they also open up hotlines for people to talk or discuss about the issues that they have. Okay, and also at the same time, they get somebody to listen to their problems and also to provide help and also some assistance. Okay, so I'm sure that probably people are now aware that there is also an app, a mental health app within our My Sejahtera application, which is called Minda Sihat. So in this Minda Sihat, they also provide emotional support hotline for people to call to discuss if there's any issues or problems. And also they provide psychosocial support information, mental health information, and also they do self-screening assessment for both frontliners and also the public. So people can actually assess their own mental health status, and as much as possible, it would also encourage them to seek help immediately. Okay, so basically there are many people who actually want to use mental health application. Like in 2010, when they did a study, they found that the demand for mental health application was very strong, where they found that more than 70% of the respondents were very interested in using mobile phone for self-management and self-monitoring of mental health if the service were free. And until 2017, they found that out of the 300,000 health-related mobile apps that were available, 490 were targeted at mental health and behavioral disorders. And another study also reported that more than 200 apps that was developed were related to mental health or stress, and it commonly targeted symptom relief or general mental health education. And in Malaysia, we have people from Pfizer who've actually developed a mental health application that can actually identify early symptoms of depression and also improve their emotional self-awareness through a mood tracking features. And it also helps users to better communicate with their psychiatrist. So we also have other Malaysian mental health apps. So just to name a few, like Plus Vibes, whereby people can actually talk to somebody, create conversation, and also get information about their mental health and also well-being. We also have an app called Thoughtful Chat, of which, again, people can also communicate with counselors and also psychologists, like if they are feeling down, so they can at least talk to somebody and share their problems and also issues and try to seek help. And also there is the Help Talk. So this was created by the clinical psychologist, of which people are able to sign up to this app, and then they can actually talk to psychologists and start their therapy online. Okay, so with all the information that I've given just now, you can see that there's actually a lot of services that have been provided by our government, by our NGOs, and also people have already started coming out with various mental health apps to help our people. But there are still gaps that have been identified. Like, for example, stigma is one of it, of which we find that most of the healthcare services that are provided are still underutilized by our young people. And this is because they are afraid of other people's perceptions. Okay. And also, most of the mental health apps that we found are web-based. And the present mental health app which are available are developed based on individual experience. So it still lacks the evidence-based. Okay, and also the content actually focuses more on screening and also interpretation of results, and it lacks the mental health intervention that is specific to a mental health problem, and also some of it often targets general population and not a specific population. So in 2017, our team was very lucky to be given a funding to come up with this program called Preventing Mental Health Problems Among Malaysian Youth. Okay, so our aim with this program was to identify an effective mobile app-based health intervention for dealing with mental health issues among youth. And this work is actually a collaboration between three disciplines, that is public health, psychology, and also computer science. So this is the general framework of this program. So we've actually started off by doing a qualitative study of which we try to identify the risk and protective factors of mental health problems by carrying out interviews and also focus group discussions with young people aged 15 to 22 in the urban areas of KL and also Selangor. So from this study, we came out with a causal structure framework for mental health problems. And following that, we did a systematic literature review, of which this review supplemented the causal structure framework that we've gotten, and we managed to come out with a screening tool. So this mental health screening tool has items that can measure people's emotional states like depression, anxiety, and stress, and also measure risk screening and also stressful life events of the user. And also we look at the coping skills of the users. So this English screening items have underwent forward and also backward translation. So we did this bilingual screening tool was administered to 154 youths to assess its reliability and also validity, and it was found to be reliable and valid. And at the same time, we managed to determine the cutoff scores. So at the same time, while doing this study, our colleagues from the computer science worked on the To Heal mobile application using this rapid application development model. So what we did then was that we incorporated the screening tool that we've produced into this mobile application, and also the evidence that we've got in terms of the activities to improve mental well-being were also incorporated into this mobile application. So if you want to check out our application, you can just search in your Play Store if you are an Android user. Inside Play Store, just search for To Heal and you can start using it. So after we have developed this mobile application, we then did a brief evaluation whereby we distributed feedback forms to about 20 respondents. And from the feedback that we've gotten, we revised the application. So we worked on the disclaimer. We've actually added some information on helpline, and also we improved on the screening questions. And also in our latest development, after it has already been revised, we've actually used the app on a community-based mental health promotion among low-income adults using online interventions, of which I will share later. Okay, so this is our To Heal application. So as for now, it is only accessible for Android users. So as I said, you can actually download this from your Google Play or Play Store if you're an Android user. It's available in both Malay and also English language, and it's currently copyright protected. Okay, so after you have, once you have already installed this application and filled up your details, you can then start to screen your mental health status or your emotional status, what you're currently feeling at the moment. So these are the various screening items that you can screen. So it includes anxiety, depression, stress, risk screening and stressful life events, and also self-adaptive skills. Okay, so once you have already completed the screening questions, then a score will then pop up for each of the emotional state. Say, for example, if you have a normal or low score, so that the color will be green. If it's a moderate score, the color will be yellow, and if it's a high score or severe score for depression, then the color will be red. Okay, so once you have already gotten your score, you'll be navigated to the intervention. Okay, so say for example, if you got a moderate score for depression or moderate score for anxiety, then the app will actually advise you to go for some music therapy, do some yoga, of which you can just click on the YouTube link, and also they also advise you to do some meditation, like for example, do mindfulness, and also provide some health education materials on mental health. Okay, so in the next step of the development of this To Heal is where we did a brief evaluation. So what we did was that we distributed online, mainly through WhatsApp, using a To Heal app link, and also we distributed the survey questions via social media, and about 20 young users actually responded. So the feedback that we've gotten so far were mainly positive. So most of the users actually knew about this app through friends and also colleagues, and also some from social media. And they also said that it was quite easy to install the app. And in terms of the screening questions, they felt that it's also very easy to answer the questions. Okay, and 90% of them also felt that the app is very helpful. So these are also some of the suggestions and comments that we got from the youth, and most of it we have already worked on it and revised and used it in our recent program. Okay, so just to share one of the comments from a youth who had depression, and this person is actually one of a member of a depression survivor group, and according to him, he felt that there was actually no issue with the app because the questions were super simple and also fun, and he felt that he appreciates because the app actually gave him the opportunity to self-assess his current mental health, and also as a major depressive disorder and anxiety disorder patient who is also on medication. He feels that this app is pretty useful because he can actually use it in between his appointments with the psychiatrist. So in summary, in terms of the evaluation, the brief evaluation that we did, the developed mobile application was accessible for most of the people, and they feel that the screening questions that were developed were easy to understand by the users, and the help is somehow also helpful in managing the users' emotions. Okay, so now I just want to share a community project that we did recently during the lockdown, because we could not run our program physically or face-to-face or go down to the field. So what we had to do was we had to use online interventions, because since many people were affected or traumatic because of this of the pandemic, and many people were actually affected, especially those within the lower income people of B40. So we decided to run this program during the pandemic. Okay, so these were the objectives of this program, whereby we mainly wanted to promote mental health self-assessment among the community using a mobile application that is To Heal. We also want to increase the community's awareness of mental health literacy, introduce to them what mental health literacy is all about. That is, they have to have a good understanding or a good knowledge about mental health, the various types of mental health problems, depression, anxiety, stress, and so on. And also the need to seek help immediately when they have a problem or experiencing any mental health problem, and also to get them to talk about their mental health and overcome the issues, the issue of stigma in our community. And also at the same time, we want to develop their coping skills to respond to whatever warning signs of mental health problems that they identify. So these are some of the different activities that we held with the community members. So mainly is to promote the use of the To Heal application in the community, encourage self-assessment and improve their level of mental health literacy, and also develop their personal skills or coping skills in responding to warning signs of mental health problems. Okay, so these are some of the activities that we've provided to the community during this program. So we did webinars and also telecounseling. So telecounseling was done mainly for those who actually were found to have severe anxiety or severe depression through the To Heal application. So we had our psychologist who actually help us to discuss whatever problems that they have and try to provide some solutions. So mainly, actually, just mainly the main aim of this telecounseling is to make sure that they were able to talk about or discuss about their problems and seek help immediately. Okay, and apart from that, with the webinar, we used it as a platform to actually engage with the participants. So we held quizzes to ensure their understanding of the content of the webinar. Okay, so other activities that we did during the pandemic through online intervention is by coming up with social media. So in this social media, like we open up a Facebook whereby we share information about mental health, and also they are also able to converse or share their experience or also problems with us in social media. Okay, we also came up with a banner that of which we put it up at the community. Like for this is one of the banner that we've actually produced, and we put it up in the neighborhood just to remind the people that whatever problems that they face, there is a solution to it, and there are people that can actually provide help to them. And also at the same time, we want them to constantly self-assess their mental health by using our To Heal application. Okay, so of course, there are some limitations to our application that we've developed, and our team constantly will work on those limitations, and hopefully we can overcome those limitations in the near future. So these are some of the strengths of our application. So basically, the questions or the screening questions that we've produced are actually easy, and it does a fast checking of the user's mental health status. Okay, and the person can actually get an immediate score, and then they will be then guided to a specific intervention based on the mental health score. And also, apart from that, this app is also versatile because because during the community project we've actually used it for elderly people, and they find it useful, and they feel that it's quite effective for them. Okay. Also, with the use of this app, we want to also increase the users' awareness and also prompt them to seek help. So when they start to fill up the screening questions and they get a score of it, and so immediately they are aware of their problem, and that would actually prompt them to seek help immediately. Okay, and also apart from that, this app also, like especially for patients who are currently undergoing psychiatric treatment. So by using this app, they can assess their own mental health while waiting for the next appointment. Okay, so in the future, this is actually what we actually are hoping for with this app. There is still a lot of work that needs to be done, especially with the intervention that is provided in the application. So what we hope to do is that we would like to come up with a better interface or features for the app. And of course, we would also like to translate it to Mandarin and also Tamil languages to capture more, or to reach out to more Malaysian users. And since it's only available for Android users, we hope to extend the app to iPhone users as well. And hopefully we can make the app more interactive, like for example, using hologram to guide users. And apart from that, we also want to have mental health experts who are ready to answer questions and have a 24/7 support hotline for more severe cases. And hopefully we can do a good effectiveness study with this application. Okay, so that actually concludes my presentation for today. But before that, we also are hoping that with this To Heal application, we can help people to also build their resilience, because we believe that this app can actually help people to know themselves, understand themselves, take care of themselves, and also to take actions immediately. So
thank you very much, Prof.
Thank you.
Sorry. Yeah, thank you very much, Prof. Nate, for the very enlightening presentation. It was actually indeed a very great effort and innovations displayed by you and your research team to address the growing trend of these mental health problems, especially in the younger adults that usually we probably have neglected in the countries, by using these e-heal applications that in which we can the young adults can do some self-screening, get access to telecounseling, as well as with all these suggested coping skills. So yeah, we actually do have a few questions in the Q&A box. Yeah, but Prof. Nick actually has to leave soon, as she has another talks to attend to. So what we'll do is we will compile all the questions and then we will email to Prof. Nick. And later on, then we will compile the answers and then post it up on the Faculty of Medicine Research Office social media after the events.
Right.
Once again, thank you very much, Prof. Nick, for being here with us today.
Thank you. Thank you, Dr. O. Thank you, everyone.
Thank you, Prof. Nick. Have a great day.
You too.
Okay. Yep. Okay. So moving on. So next, we are actually very fortunate to have Prof. Dr. Lucy Lam from the Department of Pediatrics and Ms. Riana Yam from the Yayasan Generasi Gemilang to share their expertise as well as experience on child's nutrition. So Prof. Lucy Lam is a pediatrician with 30 years of experience in dengue management as well as pediatric intensive care. She has collaborated with clinicians worldwide in developing and evaluating the WHO 2009 revised dengue case classifications. Before her retirement, she started a second career to promote child health and early childhood nutrition and development, focusing particularly on the first 1,000 days. Her collaboration with NGOs has enabled community outreach programs to better understand and improve the state of malnutrition among young children of the urban poor families. So with that, let us pass the floor to Prof. Lucy to enlighten us on child nutrition during the first. Prof. Lucy, please.
Okay, thank you very much, Lisian. I'm trying to share my slides. Okay, they are here. All right, can you see my slides?
Yes. Yeah, probably, Prof, you can put it on a presentation mode.
Yeah, okay.
Yes, great.
Yeah, okay. Thank you very much, Dr. O and the organizers for inviting me to share my experience on so my topic will cover the first 1,000 days, and this is the logo for our child health clinic, right? So the outline of my talk will cover state of the health of Malaysian public, the Barker's hypothesis, the first 1,000 days, and actually the nutrition and interventions will be covered by our next speaker, Ms. Riana Yam. So first of all, about the health of our public in Malaysia, and over the last 60 years, the lifespan of Malaysians have improved by about 50%, from 50 years to 72 years for males, and for the females, 53 years to 77 years. So this is quite remarkable improvement in the life expectancy. However, recent research released by Kazana Research Institute showed that yes, Malaysians are living longer, but not necessarily healthier. So what do they mean by that? So before, we had a life expectancy of 65 years in the 1970s, and we would have the heart attack at the age of 65 years. And because our hospital systems were not so well developed then, we would probably not survive that heart attack, and we would die very soon after. But now, with over the past 50 years, we have been the government has been investing in the hospital systems. So we would still have a heart attack at the age of 65 years, but because of the improvement in hospital systems, we would not die. We would survive a heart attack, but the remaining 10 to 12 years of our life, we live with disease and disability. So our life expectancy has improved, but our healthy life expectancy hasn't really changed that much. And that's not really surprising when we look at how the government's budget is. Only 7% of our health budget is spent on preventive medicine. So it would be better if we prevented the heart disease in the first place. Now, looking at the trends of diabetes, the prevalence of diabetes in Malaysia, these are three curves coming from the second, third, and fourth National Health Morbidity Survey. And with each successive survey, you can see that our diabetes prevalence have increased across all age groups from survey to survey. And not only that, we are also seeing younger and younger patients getting their diabetes, so much so that in their 20s and early adulthood, we are already getting type 2 diabetes. So you can imagine 2019, what would it be like, you know? So this is the latest 2019 National Health Morbidity Survey is now 1 in 5, not surprising. Okay, 1 in 5 adults aged 18 years and above have diabetes. And we look at other diseases like obesity, it was all are increasing in trend. So in Southeast Asia, we are really the #1 for the highest prevalence for diabetes in Southeast Asia. And we are also the #1 for the fattest nation in the Southeast Asia. We are far way ahead of Thailand, Singapore, the Philippines. All right. So with this high calorie malnutrition, there is what we call a double burden of malnutrition or even a triple burden, meaning that even though the person looks really big in size, but there's hidden there is the micronutrient deficiency and a hidden hunger. So that therein comes this double and triple burden of malnutrition. Now, the chronic diseases are not the inevitable lot of humankind. These diseases are not mandated by the human genome. They are the result of a changing pattern of human development. We could readily prevent them had we the will to do so. Protecting the nutrition and health of girls and young women should be the stone of public health. Not only will it prevent chronic disease, but it will produce new generations who have better health and well-being throughout their lives. And these are the words, the unpublished words of David Barker. This appeared in his obituary in 2014. And who is David Barker? Well, he was a medical epidemiologist who studied the life and birth, the death and the birth records of England and Wales. And he noticed an odd correlation on the map, that the poorest regions of England and Wales had the highest rates of heart disease. And that really flew against the mainstream thinking of that time. And this is about 40 years ago, right? That the mainstream thinking at that time was that cardiovascular disease is a disease of affluence, people with sedentary lifestyle, with rich food, the other ones with cardiovascular diseases. But when he looked at these registries, he said, no, the poorest people are the ones who had the highest risk of cardiovascular disease. So these are some of his early studies. And you can see here, these are on the y-axis events of the standardized mortality rates for coronary heart disease at the age of 35 to 74. And on the y-axis are the infant mortality rate on the left-hand graph, and on the right-hand graph is the neonatal mortality. So even though the events on the x and the y-axis are separated by about 50 to 60 years, you can see that there is a correlation. Okay, the geographical areas that are the poorest in England and Wales were the ones with the highest standardized mortality rate for coronary heart diseases. So he also noticed not only was there a link between SMR for coronary heart disease, there was also a link between the birth weight, the weight at the time of birth, the male babies who had the lowest birth weight, and those with a weight that was low at the age of 1 year had the highest risk of dying from the heart disease as an adult. So again, 50 to 60 years on, whatever that they experience is still having an effect on them. So he hypothesized that if a mother, a pregnant mother, suffers from malnutrition during her pregnancy, the fetus And that early infant conditions have a permanent programming effect on the baby's metabolism and predispose this individual to chronic conditions later in life as an adult. So in other words, when a fetus is not getting adequate nutrient, whatever nutrient he gets from his mother across the placenta is diverted to the most important organ, the brain, while skimping on other parts of the body. So resulting in the heart with less muscles, kidneys that have less renal tubules, pancreatic cells that have less beta cells of islet. And so this comes a debt that comes due for payment decades later in the form of cardiovascular and metabolic diseases. Now, this hypothesis has actually been confirmed in other studies, epidemiological studies in America, India, and Europe. And basically, to just summarize what they have noticed is also in other studies is that there is a correlation, a relationship between weight at birth and infant mortality. So the two are correlated. All right, so as the birth inversely related, so as birth weight increases, infant mortality decreases up to a certain point. After about 8 pounds, then if the larger the baby, then the higher the mortality. Now there is another event that is correlated, that is 60 years later. All right, 60 years later, the relative frequency of hypertension, type 2 diabetes, heart disease, stroke, they are also inversely correlated with the birth weight. So there is a negative correlation, inverse relationship between birth weight and coronary diseases and death from heart disease. Okay, so these are really powerful epidemiological evidence that shows that the adverse health inequities that occur in early life, such as poor living condition, poor early life nutrition, impacts not only the growth of that particular child during that time, but also determines the susceptibility of that individual to chronic and metabolic diseases when this person becomes an adult, okay, 50, 60 years later, about maybe 30 to 40 years later. So there is, with these evidence, there was a paradigm shift in the way we think about cardiovascular diseases and metabolic diseases. No longer a disease of affluence, but really this is something that happened during the developmental stage of the fetus, the stresses that the fetus has to endure during the development, stress of nutrition, inadequate nutrition, exposures to alcohol, tobacco, infections, and other medications. They produce functional changes and aberrant developmental programming. And this is permanent. So what it happens is that it alters the gene expression at the epigenetic level, and that affects the expression of protein regulation. And this, because it happens at a developmental level, it persists throughout life. And these developmental changes lead to increased susceptibility to metabolic diseases. So therein lies the new disease paradigm, developmental origin of our health and disease. Now this is a very important shift because we tend to be looking at organ-based approach to the health, but this is different. This takes a very wide paradigm, health kind of approach to diseases. So basically, a bad start lasts a lifetime, and not only that, that effect goes across the generation. So now I'd like to talk about myself and my grandmother, you and your grandmother. So, okay, the egg that eventually formed me and formed you was in my mother and your mother when she was a fetus inside your grandmother. So meaning that the egg that eventually formed you 2 generations later was actually nourished and exposed to the condition that your grandmother experienced as a young mother. All right, so when we are pregnant with our child, we are not only pregnant with our child, we are also pregnant with our grandchild. All right, so that's where the positive aspect is that the nutrients flow across the generations, but then so does all the other stresses. The stresses and the adversities also flow across the generations. All right, so that's where, child health becomes important. And in our child health clinics is basically preventive medicine. We do a lot of immunization to prevent communicable diseases, but we also spend quite a bit of time talking about nutritional counseling, so as to prevent the non-communicable diseases later on in life. So now this is what makes pediatrics so exciting. This is the importance of early brain and child development. Now, the newborn has a brain that weighs about 1/3 of a kilogram. And by the time the baby is about 2 years old, as a child, a toddler of 2 years old, his brain has already increased by 3 times in mass. Okay, so now what is actually happening in the brain? All right, the number of neurons at the time of birth is about 100 billion neurons, right? And the number of neurons remains the same throughout that childhood. But why is the brain growing? The mass of the brain that is growing is due to 2 main phenomena. One is the synaptic connections, which occur at a phenomenal of 700 synaptic connections per second, right? You heard it right, 700 per second. So much so that each neuron, each of the 100 billion neurons, by the time the baby is 2 to 3 years old, has 17,000 connections. I don't think Facebook can even rival that kind of connections, all right? Now, the second phenomena that's going on in the brain that contributes to brain growth is the myelination of nerve fibers. That enables the messages to speed up. All right, so there's so much activity going on in the brain that the brain accounts for about 50 to 60% of the oxygen consumption of a 1-year-old baby. So apart from synaptic and myelination, there's also dendrites, which allows each neuron to have more than one connection. So these branching synaptic connections, they form the foundation for the child to develop his motor, sensory, motor, emotional skills, behavior, logic, language, and memory. And this is for the rest of his life. And most of these connections occur, about 80 to 85% of these synaptic connections in our brain occur in the first 2 years of life. Right? So now the question that has always intrigued neuroscientists is, what is driving those synaptic connections in the baby's brain? They're occurring at a frenetic pace, but what is driving them? Is it nature, or is it genetic? Is it the environment? So it turns out that the studies show that it's really an interaction between the biological processes and the environment and the early experiences that the baby goes through. So I should not forget, we'll talk about the environment experiences later, but do not forget that basic health supports like clean water, sanitation, and nutrition are extremely important in brain and early child development. Right. Now, this shows you the trajectory of brain development, human brain development, and that the brain is built over time and is a continual process. And the basic architecture of the brain is constructed through an ongoing process that begins before birth, and then it goes on into adulthood. Like I mentioned earlier, about 85% of these connections have already been formed by the age of 2 years old. Now, this shows the trajectory of the different parts of the brain. So you can see here, soon after delivery, the sensory pathways are formed, vision and hearing, they're formed, and they're formed at different rates. So simple circuits are formed first, so that the more complex circuits will form over the simple circuits. So you can see here that the vision and the hearing pathways are connected first before the baby learns to articulate the words. So these languages enable the baby to express himself, to understand the world around him. And then with that, he develops these higher cognitive functions, such as reasoning, self-restraint, attention, intention, focus, and all that. So those simpler circuits have to be laid out first. And this leads to, and these early experiences affect the quality of that architecture by establishing either a very sturdy or a very fragile foundation for all the learning, the health, and the behavior that will follow. Now, this also the second principle about early child development is the interactive influences between the genes and the experience that shape the developing brain. So basically, the genetic influence is in the timing of the circuits, which circuits are formed at which time, as you can see in the previous, the early life, early in life, it is the visual pathway and the hearing pathway. So if those are formed in the early years, all right? And what is driving these circuits is that the experience that the baby, what is known as serve and return, that relationship between the child and the parents. So the child has an innate tendency to reach out for interactions. And if the adult, the caregiver, reciprocates and returns, there you form the serve and return. The circuit is complete. So that is as simple as that. It couldn't be simpler than that, all right, to form the brain circuits. Now, so it's these serve and return interaction between the baby and the caregiver that shapes the brain circuitry. However simple as it may seem, if there was the absence of such a response, so if, for example, the adult was too preoccupied with depression or other worries about their food insecurity, then they may not be able to respond to the baby in such a in a way that that will reinforce these circuits. And the absence of these responses will affect the architecture and affect leading to learning and behavior problems later in life. Now, the third principle about early brain development is the neuroplasticity. That is the ability of the brain to change in response to the environment. And this neuroplasticity decreases with age. So this is a conceptual graph of from many studies on humans and animals. And it shows that the brain's ability to change in response to experiences is very, very high in early life, all right? But this neuroplasticity decreases very steeply, okay, in the early years, and it decreases gradually towards for the rest of the person's life, but never goes down to zero. So I'm so glad because I'm in my 60s and my neuroplasticity, there's still some residual neuroplasticity, but it also means that it takes a lot more effort for me to learn. So in the early years, before the age of 5 years, it takes less time, intensity, and repetition to organize the developing neural system than it does to reorganize a system that is already developed. All right, so if you try to fix it later, it becomes really difficult. So it's easier and less costly to form strong brain circuits during the early years than to try to fix them later. So therein lies the concept of sensitive periods and the critical periods. So basically the sensitive periods, so the early experiences play an important role in shaping modifying the biochemistry and the architecture of our brain circuits. And these experiences, they only operate within a limited time frame. So during that time frame, the brain is very receptive to positive nutritional and social stimulation. All right, so when it operates within that time frame, that period is known as the sensitive period. So during this sensitive period, whatever connectivity among the neurons that are formed actually stabilized as a result of the exposure to the early environment. So there is an environmental adaptation, right? The brain development is an adaptation to this. And these pathways can be altered later in life, but it's limited by your neuroplasticity. However, if a given and when experience in a given period is crucial for normal development, for example, exposure to natural light is important for the visual development in the early days after birth, then if the baby is deprived of that, then, the visual acuity, that may affect the visual acuity, the sense, the color sense, and the contrast may not be so stable as strong as if a person were to be, a baby were to be exposed to natural light. So that's where the critical period is. However, there will be some degree of neuroplasticity, some that recoverability, but is limited by your neuroplasticity. So therein lies that opportunity and the vulnerability. So the early life nutrition on the brain structure, in the lack of this nutrition, these have been shown to lead to long-term consequences that may be irreversible, such as iron deficiency anemia has been shown to impact on learning problems later in life, decades later, after you have treated the iron deficiency. So there is a very important need to focus on stimulation and the nutrition in early childhood. So the first 1,000 days of life is a critical period when the foundations for subsequent optimal growth, health, and neurodevelopment of a person is established for his entire lifespan. So what are the first 1,000 days? It is who you are today was shaped in the first 1,000 days. So it includes 270 days of pregnancy, plus 365 of the first year and another 365 of the second year. And that makes a total of 1,000 days. And that's all that we have to really shape the brain circuits. Now, so moving on, I would like to talk about this particular study. And this is a study sponsored by WHO, and it looks at growth in the first 5 years of life. And this was a study that gave rise to all the international growth charts that we in PPUM use to calibrate our babies when they are growing, where they are growing. So this study, when it was conceived back in 1990s, and it took many years of planning to do it before they actually implemented it. So it covers 6 major areas of the world: Asia, Middle East areas, Africa, Europe, North America, and Latin America. Okay. So it is a very comprehensive. They made sure that the places that are involved in the study are multicultural as well as multi-ethnic. And the mothers who were involved in the study, they had fulfilled the criteria of exclusive or predominant breastfeeding, at least for 4 months, partial breastfeeding up to 12 months, and having a supportive environment for growth. Mothers are non-smoking, and the complementary feeding had to be introduced by the time the child is 6 months old. And this is the chart that they showed. So you can see the areas, all the areas, every country contributed to these charts, and you can see that the length of these children is not much different when they had good food and care. So when given adequate nutrition and care, children grow similarly despite our ethnic backgrounds, meaning that genetics probably have a very, very small impact, if any, on the growth in the first 5 years of life. And what is probably more important is the epigenetics on the role of the environment and the nutrition that plays an important effect on our genes that play an important role in early life. So the message is very, very clear. When health and optimal nutrition are met, the world's children grow very similarly. But in reality, we don't have that kind of picture. Look, this is a UNICEF study in 2018 that actually calls for help, that Malaysia's nutritional state is in a dire situation, and the Malaysian children are more stunted than those in African countries. And so this is a study which looked at low cost, the children living in urban poverty and deprivation in the low cost flats of Kuala Lumpur. All right, so this is looking at the underweight, stunting, and wasting. And even in a place like Putrajaya, which is one of the richest districts in Malaysia, 1 in 4 children are being stunted. And children in Kelantan, 1 in 3 are being stunted, compared to Zimbabwe and Swaziland. So we are in dire nutritional status. All right, so there are different types of childhood malnutrition. There is a wasted child who is low for his height. His height is still okay, but he is low weight for his height. A child who is stunted, who is low height, he's short for his age, and a child who is underweight. His height is not as good, but he is definitely both. All right, so what these represent is that the wasted child is suffering from acute undernutrition. Maybe he's had diarrhea for about a week or so, so he has lost weight, okay? But it is not long enough to impact, the period of undernutrition is not long enough to affect his height. But if this goes on chronic for many, many months, and then this child will eventually be stunted. All right, and a child who is underweight is going from acute chronic undernutrition. So these children, especially the stunted children, they are very well adapted. They're adapted to this chronic deprivation. So they usually don't get sick. They don't usually come to the hospital. So they are really not on our radar screen. Now, malnutrition comes also in other forms like obesity, right? Overweight is also considered. So what are the long-term effects of stunting? Short and long-term effects of stunting. Short-term, the brain development is impaired, the immune system is weakened, and the IQ is lower. They are more apathetic, less positive affect, lower levels of play, and more insecure attachment. In long-term, these will become shorter adults. They lost their productivity, healthcare costs, premature death, greater risk of diabetes and cancer. And they have more problems with their conduct, poor attention, poorer social relationship with school, poorer school achievement, employment, and so on and so forth. So this goes on intergenerational cycles of malnutrition. So a stunted child who doesn't do well in school, drops out of school, gets married, and is a malnourished young girl, drops out of school, gets married young, malnourished mother giving rise to a underweight baby. So the cycle goes on to the next generation. And this really fulfills that developmental origin of health and disease hypothesis. Now, looking when is the child most vulnerable to malnutrition? So this is a study in Guatemala, and it looks at the time when the rate of malnutrition doubled is between 6 months to 24 months. Okay, and this is a time when the baby is being weaned from entire milk-based diet into solid complementary feeding. And this is the most vulnerable period, and for iron deficiency, for growth failure, and so on. Now, looking at the stunting rate in the prevalence in Malaysia for children under 5 over the last 20 years, in year 2020, the year that we are supposed to be a developed world status, our stunting prevalence is actually higher than it was 20 years ago. So that really doesn't bode well for the state of our nutrition. So what does under 5 stunting means is a measure of chronic undernutrition, pairs with infectious diseases, inappropriate feeding practices, and definitely poverty. And then stunting by the age of 2 to 3 years old is associated with later cognitive deficits, school achievement, earlier dropout, and not only that, it goes on to obesity and the diet-related non-communicable diseases. So in this trajectory of human brain development, where the child's brain is developing at a rate that is never going to be matched ever again for the rest of his life, where are these children? Where are them? Where are we in relation to these children? Okay, they're in the first 1,000 days. Their brain is never going to be developing at such a rate again. So this is where they are. So every one of these arrows is a vaccination visit. So they're actually visiting us for their vaccinations. But you can see from the color of these arrows, the dark colors, the dark red, the first and the last arrow is the only time when they get to see a doctor. Everything else in between, all the other times in between, they're seen by the nurses. All right, so this is where our problem lies. Okay, so it's a critical window. That window is available to us for action. All right, and if we fail to do that, it is also a time of greatest vulnerability for that child. Okay, so the ramifications of this is really enormous because it's large, because the failure to optimize brain development early in life has led to long-term negative consequences with respect to the child's education, job potential, and adult mental health. And it's these long-term consequences that are the ultimate cost to society of early life adversity. And this will really undermine whatever investments we have made in our human development in this society. So it's much easier to build strong children than to repair broken men, right? So this is a framework that is proposed by these authors and is used by WHO. Basically, for a child to maximize, to optimize his brain development, he needs good health, nutrition, security, and safety, responsive caregiving, and early learning. So these 5 domains, 5 pillars of a nurturing framework, care framework, they are all interdependent. However, when there is a compromise in one, then eventually all the others will also fail. So in these 5 pillars of within the nurturing care framework, the one that is most amenable for intervention, I would say, is the nutrition. Right? So we need to do this so that we can achieve our sustainable development goals by the time we are year 2030, not too sure whether we can achieve that. And I think the pandemic has also shone a spotlight on the cardiometabolic risk factors. This is a study that was reported among the admissions in America, patients who were hospitalized for COVID. They could find that 63%, 2/3 of these hospitalizations were attributable to these 4 cardiometabolic conditions of obesity, diabetes, hypertension, and heart failure, right? So I think the COVID has really kind of like a convergence between communicable diseases and non-communicable diseases, and how we are going to develop our health systems is going to be dependent on how we respond. Okay, we really need to build back a better health system in order to face this pandemic, or else we are never ending circles of like, this pandemic is not going to go away from us. Okay, with that, I'd like to thank you for your attention. That's my last slide. Anything else?
Yep. Thank you very much, Prof. Lucy, for your really enlightening, I would say, education or lessons that are educating us on how important the first 1,000 days is from the conceptions of pregnancies to the baby's second birthday for nutrition interventions. So yeah, as I myself as a scientist with a particular interest in genetics, I think it's really interesting to know that just now, Prof, you mentioned that genetics may not play a very big role, during the child's early, but indeed, yes, like nutritional and social stimulations actually have an effect on maybe the genetic reprogramming that allows like brain adaptations to the new environment and brain development.
Yes,
that's really interesting. And just wondering, just a question is that if malnutrition already occur during the pregnancy period, where it really affect the programming during the embryo development, is there any advice that Prof you will give to sort of like reverse the conditions, or would catch-up growth actually helps on that?
Yeah,
or would have adverse effects?
I think that is a very, very important question, because we do have about 10% to 11% of our babies are born with what we call the small for gestational age, which means that they have already suffered malnutrition during the fetal stage. And so once they are born, sometimes in the first year, we have to keep them very closely under our radar to make sure that they get adequate nutrition. And I could say that most of these children, they do catch up with their growth in terms of height, weight, and head circumference. Very important, the head circumference. And most of these do catch up. But however, there's still a minority, those really like those who are born 1.6 kilogram, term 1.6 kilogram. It tells you that this nutritional deprivation has been going on for a long time. So it's going to be really where we keep them in our follow-up, but they haven't really come out of the third centile. They're kind of hovering on the third centile, -2 standard deviation for height, weight, and even the head circumference is well below that. And we see that in our child health clinic, we see that in the community as well. So I think we can only reverse to those who had not been so malnourished for that chronic period of time.
Right. Thank you, Prof, on that. Yeah, we have
and
one,
also in these children.
Yeah.
So for these children, we had to counsel the parents on the healthy nutrition because they are at risk of cardiometabolic diseases later on in life. So if we can at least keep them on a healthy diet, healthy lifestyle, we can try and avert these. So we have to educate these children. In the past, we never followed up these children because they survive. They don't have problems with their breathing. They look kind of well, but they're actually not well. They're kind of like there's a hidden hunger. And if they do not optimize their nutrition, then they never catch up, which would be a pity because we are not a poor country. We just don't eat well. That's all.
Right. Yeah, and we actually have quite a number of questions in the Q&A box from your interesting talk. One of the questions by Livia was talking about how about, because Prof, you mentioned about malnutrition. How about overnutrition? Is there such a thing like consuming too much proteins? And if yes, how do we monitor so that to ensure that we don't overfeed our toddler?
Yeah, okay. So we try in our counseling, we tell them that WHO has a food chart, food groups, and we try to make sure that they are not like milk-based. A lot of children, they're growing very well because they drink milk 8 ounces 8 times a day. They will definitely grow well. And then everybody will say, oh, you're so good. What milk did you drink? But actually, when you look at the food groups, the diversity is not there. The diversity, you're drinking milk, but you're supposed to, it's not good for your microbiome to just drink milk. You need the other food groups, the plant proteins, the eggs and the vegetables, the vitamin A and the green leafy vegetables. So we use that food chart to educate our parents. I think later on, Rihanna may be talking about it and to tell them that you really need to diversify. Make sure that you get all the 8 food groups in. We can afford it. In Malaysia, we can afford to have 8 food groups. Although WHO says minimum of 5 food groups, I tell you in Malaysia, people eat 4 food groups or 3 food groups, not because they are poor, but because out of convenience, out of ignorance, out of whatever, we are not eating well, not because we are poor. We are not poor, but I look at the parents, they are not B40s, but you look at them, the way they feed their child is like, all right. So overnutrition, if they are eating the 8 food groups in a very balanced way, you will find the children growing. Actually, we do have quite a number of children. They're growing on the 97th centile for their height, 97th centile for their weight, and 97th centile for their head circumference, which means that WHO was right, that if we give them adequate food, our Malaysian children, whose parents are not very tall, but given that good adequate nutrition in the first 2 years of life, they actually grow very well. I was like, oh, wow, this is true. WHO was right. That chart was right. So I'm really inspired by the way they did the study. And we really want to emulate them in our future projects, that let's get the parents to buy into healthy food.
Right.
So,
I guess that actually sort of answer one of the questions by one of the anonymous attendees, that what do you consider a balanced ideal diet during the first 1,000 days? And what can we parents do to promote this? So I guess we will hear more from Miss Rihanna later. And yeah, there is also another question. This says, interesting thoughts on neuroplasticity. Neuroplasticity can be improved according to Dr. Kaylee Lambert, sort of talk in TED Talk, that her theory is about brain plasticity can be improved by exercise and readings, in which it actually promotes motor recovery. So what's your thoughts on that, Prof?
Yes, I think that, in the graph, that conceptual graph that I showed, neuroplasticity doesn't go down to zero. It only zeros when we die, on the day that we die. So the brain will always be able to grow. It's whether we are able to use our brain. So you use it or you lose it. It's simple as that. It's like every part of our body, all right? You either use it or you lose it. If you use it, it grows. If you don't use it, then it atrophies. In those days, we used to use the word disused atrophy. So the brain does go through the same disused atrophy, which is one of the reasons why I still have to work. I don't want to go into a disused atrophy. I think all of us should do that.
Yeah, and there's also another question is that asking Prof if you can clarify why is obesity a dual burden malnutrition?
Okay, so like I said, if we eat our fresh food, which Rihanna, I don't want to take the talk away from her, but she's going to introduce all the fresh food. Okay, the fresh food that WHO recommends. So the first group, I'll just quickly go through carbohydrates, there's the rice and all that. And then number 2 is the plant proteins, which a lot of us, the Eat Lancet Commission says that there is one food group that all of us need to eat and which we don't eat enough, that is that has caused us to die prematurely, and that's the plant protein. All right, so that is the seeds, the nuts, and the tofu, tempeh, and all that. So we really need to eat that. That's number 2. Number 3 are the animal proteins that, of course, as an adult, we need to reduce that because the red meat, is now associated with colorectal cancer. And then for children, they're not so bad yet, but they need to have some form of animal protein. That's the 3rd food group. The 4th food group is the dairy products, dairy protein like milk, cheese. And then the 5th is breast milk from mother. All right, and then the 6th is eggs, which is very important for children. So a lot of our parents, they are so scared about cholesterol, so they no eggs, no eggs, no eggs. So that gives rise to egg allergy. All right, so then the 7th is the vitamin A rich, which are very important for our immune system. All right, so these two, the last 2 food groups, the vitamin A rich and the green leafy vegetables, they are important for our microbiome. Okay, and this pandemic really has thrown that spotlight that the microbiome is the real determinant of our immune system. How reactive are we? Are we able to regulate our immune system when we are invaded by the COVID virus, or are we overreactive? And that depends. I think the studies have also shown, there's one study that shows that people on the healthcare, the frontline workers in Europe and America, those that came down with COVID, the severity of that COVID is actually associated with a lack of a plant-based diet. So those frontline workers who were really at the forefront of fighting the COVID, if they had a plant-based diet and they came down with COVID, that COVID was a relatively mild, like a common cold kind of COVID, right? Whereas the rest who are on animal diet and all that, they are the ones who come down with the severe. So really, I think that it's a message from nature that we need to get our act together, see our health, not see disease from an organ point of view or disease specific perspective, but look at health as a whole, mental health, nutrition, and see it from a very holistic point of view. So when we are eating those natural foods, you're not going to be obese. What makes a person obese is they're not eating those type of foods, but they're eating the biscuits and the milk, which we see in our children, in our community. Their diet is Oreo biscuits, 3 or 4 packets a day, plus 4 or 5 bottles of milk, formula milk. They will grow, but they are malnourished. They don't have fresh food. They don't have micronutrients. They don't have phytonutrients. So that is when you get a COVID. what have you got to modulate your immune response? Your microbiome is completely mucked up with the food that we eat. So I think that we are going to pay, I think there has to be a lot more research into the microbiome. Definitely the microbiome plays an important role in our immune system, but how the nutrition, our diet plays an important, how we regulate our microbiome, our gut microbiome with our nutrition. So that's going to be important. So these people who are big size, they are tall, but they are really quite soft in the sense. They are lacking in micronutrients, phytonutrients, and the antioxidants that are important. Yeah.
That's a very important insight, not just for children, but also as for adults.
Yes, yes.
We need to take note
exactly. Yes.
Yeah. I think moving on, yeah, maybe we can keep some of the questions later on. So we moving on. Thank you so much, Prof. Lucy. Yeah, I hope you can stay with us until the end of the session.
Yes, we will stay. Yes.
Yeah, great. So moving on, I think we shall welcome our next speaker of the day, Miss Rihanna Yang. So we are fortunate to have Miss Rihanna Yang, who is the head of partnership divisions from the Generasi Gemilang Foundations, and she is an international business management graduate with managing various stakeholders in the Generasi Gemilang Foundations, or more also known as Yayasan Generasi Gemilang. So this Yayasan is a charity organization on providing education and basic needs to the vulnerable communities in Malaysia, with the aims to improve their livelihood. So her role sees her working closely with corporates, companies to align their CSR goals with the Yayasan's works in order to meet social needs. So believing that all CSR programs should be meaningful and impactful, she is constantly on the lookout for partners to collaborate with, putting the strength of a few together to maximize the impact of projects she takes on. So from initial meetings to churning out impacts reports, she and her team manage 20 over corporates that works with this Generasi Gemilang on a yearly basis. So in no time, I would like to extend our warm welcome to Miss Rihanna to deliver her talks on Project Makan Sihat, a toddler nutrition program for the B40 communities.
Thank you so much, Lithian. Hold on, let me just share screen, yeah. Hold on.
Yep.
Mana? Okay, let me share it. Can you all see my screen?
Yes, yes.
Can? All right. Hi, everyone. Thank you so much. Yeah, thanks so much, Lisa, and thank you so much, Prof, for the opportunity to collaborate with our organization. And yeah, really thank you for this opportunity to share a little bit about our project and a bit about what we do in terms of our collaboration with you. And yeah, so my name is Rihanna, and I am from the partnership team in Yayasan Generasi Gemilang. And what my team and I does, we do a lot of collaboration with various partners from different strengths, different capabilities to meet needs in the vulnerable communities that we serve, specifically for education and basic needs. And it involves piloting projects like Project Makan Sihat with different multiple partners as well. So just like Prof, I know she feels very strongly that we need to start early when it comes to nutrition for children, and I do believe that as well. And for Gigi, Generasi Gemilang, our mission is to provide education and basic needs to vulnerable communities so that we can, improve their livelihood in the long run. So through our programs, what I'm going to do is I'm going to share a little bit about what we do, and we'll connect that to our experience working in this in Project Makan Sihat and what we have been doing together with Prof and what we ourselves have been seeing through our lens from the social sector, as well as from our professors' strengths and her team's strengths. So through our programs, I think there are three things that we want to achieve in GG, where we want to give increased access to education to children. We want them to have improved skills and learning. And lastly, to really strengthen families. I think family environment is very key for a child. And this is where Project Makan Sihat comes into play, because again, it is about educating the parents so that you can create that environment for the child to start having a very healthy eating habit. So Project Makan Sihat is a very fairly new project for us. We're not new to the food aid intervention. We've done a couple before, even when it comes to the COVID response. But Project Makan Sihat has taken us up to another level where it talks about, nutrition for these communities that we serve. So what it does is it aims to improve nutrition and health of pregnant mothers and children through the provision of fresh food boxes and coupled with nutrition education and support. So it started off in July. Prof and her team started way back in July, and I think we met around that time as well. And then the project ended until around May. But I think the key turning point was when we really pushed through in December through a special grant by MOF with a grant by Yayasan Hasanah. And the project itself is not only just about, improving nutrition and health. It is about involving multiple collaborators. We had community leaders involved, fresh food suppliers. We had even the Malaysian Pediatrician Association, Prof's team, many others. And I think the whole idea is to also create, an ecosystem for the community that we serve, so that it can be we have a very sustainable nutritional education and support for them, because eventually we want them to be empowered with choices they make when it comes to healthy eating habits, which I think Prof has mentioned. A lot of them tend to turn to ultra-processed food, turn to things like that. And I think we're here to also educate them. We're also here to empower them in how to make right choices for their children and their next generation. So as I mentioned, how it came about was there were issues that we have picked out, which I think I won't really elaborate further because Prof also mentioned. One is malnutrition in the communities that we serve, mainly in B40 communities, what we call the underserved communities. And I won't elaborate further, but yes, there's about 17.7% of children in Malaysia are mainly stunted. And of course, there are all the effects of delayed brain development, which will then affect the child in the long run. But what we also have seen is food insecurity. So in the recent report by UNICEF called Families on the Edge, we've seen that 6 out of 10 families are unable to purchase enough food for their families. And this is quite alarming. This is something that we've seen even through our food aid interventions in the past. I think most of it is due to the lockdowns that has created unemployment, income reduction. And because of that, we've seen even greater amount of families turning to less cheaper alternatives, and where the child's nutrition becomes less of a priority, because all they are looking for is to try and put food on their table regardless of the quality. And I think another thing is we've also seen, Prof has mentioned, lack of guidance or even that education on what exactly are nutrient dense foods, and because of that, I think the health of the family in the long run becomes very compromised, as also Prof mentioned. So these are the two issues that prompted us hey, we need to do something about it. We need to intervene. And so our solution are 3 things. We decided to work together in a PPR in Ara Damansara, which we've done programs before. And 3 things that we thought of is, 1, we need to address the food insecurity issue, which is to provide their basic need, fresh food boxes for the family and feed them as well whilst they're trying to get food on the table. So with that is a twist. It's a fresh food box intentionally curated, to provide adequate protein, vitamin A rich foods, iron rich foods, protein rich, nutrient dense fresh food boxes for the families, and whole ones. And they are done bi-weekly from the time of the program in December. The time is we kickstarted officially in December all the way till end April. So I think with this, we're also finding the reason why families also don't, are not able to access or even maybe prioritize buying fresh food items. It's very easy for them to turn to ultra-processed food. It's convenient for them. But the thing is, as Prof mentioned, they are very energy-dense, nutrient-poor foods, and that's where we need to start providing that first. Our second solution then is creating the awareness on their child's development. So see, I think the mothers that we engaged with, they are very concerned and they'll be very willing to go the extra mile for the sake of their child's development. But the thing is, a lot of them, they simply do not either have the time or that capacity or that even that know-how on understanding their child's development and where they're at. And this is where, Prof and her team, they come in with the expertise, to do pre and post assessments, like in a form of health checkups in the community itself, so that we can connect with the parents. We're able to, help them to be aware, where is your child at this moment? How do you then get from point A, where your child is at, and to point B, where your child is supposed to be? And that's where we create the awareness for them. And eventually, it doesn't stop there. We believe in going the extra mile again to provide nutritional education and support throughout the period of that project, because we believe it's not just a one-off, we share with you your awareness, but we need to guide them, we need to journey with the families. And this is where we run, support group chats, workshops for the families. We create a sharing platform for the mothers and the parents to share their recipes or tips amongst themselves on how to, get their children back on track in terms of their nutrition. So these are the 3 solutions, and I'll share a bit more. I'll share more photos on this as well. So when a family wants to start off their child in Project Makan Sehat, we have what we call a pre-assessment, the health checkup. And the first thing they need to do is then go through the stations, the usual, measuring the weight, the height. They conduct a dietary diversity questionnaire, like a 24 hours food recall questionnaire with the parents. And then we do a blood test if the children is willing or the parent is willing. And lastly, I think the valuable bit really is the one-to-one nutritional counseling by pediatricians from Prof's team. This is where we really sit down with the parents. We tell them, okay, this is where your child is at. What has your child been eating? Get to know them a little bit more. And we then review the dietary diversity with the parents on the spot. And then later on, we also share guidelines on, the 8 food groups, as Prof was mentioning, how do you then have that healthy plate portion? What exactly are ultra-processed foods? So it's a little counseling education session, very personal with the particular parent. And then we tell them, okay, when we have the next assessment or when we check in again, I just hope that your child is able to, expose themselves to more food groups, because majority of them on average is probably 4 to 5 food groups, and that's about it. So we want them to be exposed to keep exploring textures and different food groups as well. So this is the key point to kickstart the family, telling them where they're at in terms of their child development. And then only we go on with fresh food boxes. We give them on a bi-weekly basis. So the fresh food boxes, again, as I say, it's very, intentionally curated. And we engage with Grace Market, another fresh food supplier. And this is not just a normal fresh food supplier. They're a social enterprise that provides surplus food from, surplus produced from farmers. And it bridges the gap between food insecurity and food wastage, while we benefit the farmers who are providing that surplus and even suppliers in the community. So even when it comes to items in the fresh food boxes, they're also curated and supplied by community within the community itself. So we're also not only supporting them, we're also supporting generating income for those in the community as well. There are 2 kinds of food boxes. So it just varies depending on the number of children in our project. And so if I were to share with you the long list, this is the kind of what we introduce. If you can see here, it's like a variety of colors, a variety of food groups. And I think the key thing that kind of struck us personally is the chicken liver. It's cheap, but it's very nutritious, iron rich, as we all know. And then the rest, we also put in fish, kailan, things like that for even the ones with the higher value food box. So in this food box, we also put in, a note telling them, hey, you're now congratulations, you're starting off with this Project Makan Sehat. Here are a few recipes to try out based on, what you have in this fresh food box. And so this is where we kickstarted and we let the families begin to, use these fresh fresh food boxes on a bi-weekly basis. Of course, there might be questions like, oh, they have more than 5 siblings. What do you do with them? Is it just only one child? So what we do is we just cater for that, whatever number of children who's of that family into that in that program. But in the long run, we also want their siblings to, we just leave it to the families to cook whatever they want based on that fresh food box. But in the long run, we hope that that act alone will influence the family members and even siblings to have that healthy eating habit in the long run. So we don't stop there. As I said, we also do that educational support. And this is where we created group chats with all the mothers. And then we tell them, hey, this is a platform for you to share your recipes, share your tips, share your cooking photos. That's where we got this. So if you see on your left, you see this square thing. This is actually chicken liver powder. And it was something that we picked up from one of the mothers in the community. They have a technique to make chicken liver edible for the child, because we all know some of us are not accustomed to the taste. So she has created this, and it's something that even Prof has even shared to some other mothers, to use it and to sprinkle it in food so that it becomes like a very nutrient dense item that the child can consume without noticing that it's there. So these are the things that we also share in our support groups, recipe sharing, and even encouraging them to keep sharing photos as well. We also do workshops, and this is where we also learn that physical sessions is very key for communities like this. They love being with each other. They're very communal. And so when the opportunity this year allowed us to go back on ground physical for a while, we actually quickly did up a workshop together with a speaker from UM to talk about adult nutrition, because it's not only just about the child. We want the mothers or the parents to also be empowered to take that decision on themselves. And so they can play a very good role model for their child. So what we did was we also had stations. We also shared with them local, the calorie count and even the nutritional information from some of the local dishes, just so they have an idea like, okay, certain things I need to take things in moderation. So we also had that, and we found that it was very impactful, I guess, for most of them, because there are tons of questions, which a lot of them may not be able to address in the support chat group. So a very good balance between workshops like this and even personal support groups are very key to, journeying with the families when it comes to nutritional education. And lastly, we close off with another post-assessment. Same thing as the pre-assessment, we go through all the stations. And if you see on your left here, there is actually a child's play area. And this is where our, in terms of our collaboration with UM, we also bring in our expertise, because we also do children's services, and we are able to engage with them well. So we also created a play area so that the child doesn't feel like they're going into a clinic for a health checkup as well. So this is roughly how it runs in terms of our post-assessment. So after all this is done, Prof's team will then take on the data and will begin, analyzing it with her team. And I think what we found are very interesting findings in that performance. I would say it's very satisfactory. So what is the impact after all this 4 or 5 months? We go back then with this question: what are we measuring against in the first place? What are our objectives? One is we have always wanted to see improvement of the child's development and health, right? And how we do this is to measure the stunting, wasting rates, height, weight, iron levels from the blood test. And what we found is that the prevalence of stunting has decreased, from 21% to 9.3% for children aged 2 years and below. And another one that I didn't mention here is that, when the team analyzed the blood test, we found the levels of iron stores and hemoglobin itself has maintained for, all the children, maintained throughout the months, which is great. For a short period of time, at least it didn't deplete. And secondly, what we also look at is you want to see improvement in nutrition education. the desirability of healthy foods. We want them to have improved dietary habits. So this is where the nutritional support comes in, right? And what we did was we worked with student volunteers from UCSI who were also doing, nutrition, studying nutrition, and we came up with this knowledge application sort of survey, which is done pre and post, just to assess the perception of, the parents when they observe their children, whether that the children have increased their frequency in eating certain food groups. And what we find is that, 24 to 29% of children stated that, parents stated that, there's some improvement in their children's consumption habits, meaning their children are eating vegetables and fruits more frequently, which is great. But of course, what I didn't put here as well is we found that 60% of them stated, okay, their children either retain or some of them increase their frequency of eating ultra-processed foods. So that is something to take note first. We also did calls because we wanted to get stories, real-life stories of, whether nutrition education, the perception of the parent in this program has also changed. And we also want to find out, how the parents are viewing Project Makan Sehat. So we called a few mothers and just asking them, like, what do you value the most about Project Makan Sehat? And most of the time, we all tend to think, okay, it's the food lah. We give out fresh food, it's free on a bi-weekly basis, it's great, that's what I value. But no, most of them actually said it's not the food aid, it is the consultation, it is the nutritional support, the nutritional counseling with Prof and her team, just understanding where their child is at, getting tips from us like, okay, how should I feed my child pumpkin and get them used to eating tempeh, for example. Things like this are things that they never learned before. A lot of information have been passed down from their generations, and they kept saying, my mom never taught me this when I was pregnant. My mom never taught me that I could continue breastfeeding. And my mom is okay. I never knew certain things. So I think they valued that consultation advice, and because of that, it has given them this renewed motivation to really be serious about their child's development in terms of the nutrition. Lastly, I think we also want to see improvement in the dietary habits. What we mean is like to have more exposure of food groups. So through that whole 24-hour recall questionnaire that Prof and the team analyzed, I think we found that children below 2 years and 2 years and below, the number of food groups on average from the beginning was about 5. So it kind of increased to 6 food groups, and the increase is due to the fruits, the consumption of vitamin A rich fruits and vegetables. However, as I wrote here, children above 2 years old, we found that 92% of them still continue consuming sugar sweetened beverages. And in fact, if we were to look at all age groups, roughly 40%, 49% still consumed ultra processed foods. And what are we seeing here? We're seeing that all this, the consumption habit itself, it is an intergenerational habit. As Prof mentioned, they're very used to, turning to cheap alternatives. It's very convenient. But we realize that this sort of habit is very difficult to wean off within this short period of time. In these 4 months, it's not enough for us to change the perception at all. So what we are seeing is, yes, there is some increase in consumption of fresh items, but again, all this doing away with the habit of eating ultra processed foods and things like that is something that needs to be addressed in a longer period of time with strategies, again, because all these habits have been ingrained in their families for generations. So where are we? What's next for us? The project officially, sort of ended in May, June, but we are actually continuing it. We have a next phase. We are continuing the project with the same group of families, providing them the bi-weekly food boxes. We want to continue empowering the community. We want to continue journeying with these families. And so as Prof and I thought back about this whole first phase of Project Makan Sehat, I think it has inspired us to think about several things. in the long run, in order for us to have sustained nutritional support in this community. One is that I think we need to think about empowering the community to advocate healthy eating habits. So it doesn't need to come from us. We want the parents to really start advocating within their community so that whole, it will start spreading in the community. Everyone will want to, jump on to have that, the inspiration to continue doing that eating, to have healthy eating habits. I think secondly is, other collaborators, there should be other collaborators like, institutions, institutions, educational institutions, they can adopt similar interventions in their selected communities. It's not to say it's not doable, but it's something to consider because, there are many communities, underserved communities out there that need this sort of intervention. And I think thirdly, we didn't think about key NGOs or even government bodies that specialize a lot in food aid programs. We just hope that, they will be inspired in enhancing the existing intervention programs already to address not only just food insecurity, but to address malnutrition for younger children. So at least it's like killing two birds with one stone, rather than, keep going on with like dry items all the time. But I think we should look into enhancing it, improving it, through by creating a twist in this food aid intervention. So I think as Prof and I were also talking, as we were also reflecting on the number of collaborators we have, I think what we found that it does take a village to raise a child. As I mentioned earlier, way before, when I started my presentation, it is about also working with multiple collaborators. We have community leaders, student volunteers from UM, from UCSI. We had even like funders and even grant providers. It's a mix and it's a melting pot of collaborators. And that's why I would say it's not easy, but I think with a lot of collaboration, it really will pay off. And as I said, it's something that we cannot do alone. So I think for us, I think we would like to really thank our collaborators for this opportunity. And I think we hope that, as we continue Project Makan Sihat, or if let's say, other NGOs or other organizations would like to look into this, do consider really meaningful collaborations with other, within the community or even outside the community as well. So that's the end of my presentation. I just hope that, the audience out there will be very inspired by our little project, which I believe Prof is very, very passionate about. Thank you very much.
Thank you very much, Ms. Rihanna. Indeed, we are actually very inspired. Thanks for sharing your journey with us. I think while Prof. Lucy's talks just now was educating us about importance of child nutrition from the clinical evidence or public health point of view, your sharing actually allowed us to have more insights from a social sector point of view instead. So it's a really great example of work that have real life impact affecting the real communities. So yeah, just wondering so during these pandemics, I was just thinking balanced healthy diets may be compromised even more during these pandemics where people probably emphasize more on feeling full with inclination on more sugar intakes rather than a balanced diet. So just wondering with the movement restrictions during pandemics, how do you reach out to all these people who are at a greater risk?
Yes, so good question. So that's why we engaged with Grace Market, and they are able to work with community leaders, just dropping it by Lala Move. So we really had to be creative one. Wow. We had to work with even Lala Move. Grace Market will work with Lala Move and just pass it on to the community leaders. And that's the very important part. So the community leaders are our connectors to the families. In the past, before the very strict lockdown, we could do it door to door. But yeah, with all this, we worked very closely with them. And the community leaders will then arrange for families to come down and quickly get the food within a certain time period.
Right, it's really great to know that it's still ongoing even during such a difficult times. Yeah, we actually have quite a number of questions in the Q&A box. One of it is, I think Prof. Lucy is typing the answers. Maybe you go on to the next one. It says, do you have a website for resources or reference for child nutrition that we can actually refer to? Focusing on Malaysian food will be even better.
Yes, there is a website. I'm sorry, I can't remember, but there was one that I came across by the yeah, there is a website. I'll answer this. I'll type the answer because I remember I opened the website for this. Specifically, it was done by one of this corporate organization who was also was talking about eating healthy. So I can share with it. But actually, there's many other resources specifically for Malaysian food, if I recall correctly. So I can put the answer. I'll put the answer there as well.
Thank you very much. And I think it was very interesting as you showed just now how you actually have like liver powder, like liver made into powders, chicken liver. It was like, very innovative and
very the mothers actually, I would say I think Prof and myself and our entire team felt we learned a lot more from the mothers than we, because they're actually very skillful. They know how to go their way. They're very resilient now, I must say. So but it's just a matter of coordinating and having the message, like, sharing that platform. And then on our side, we're also sharing the knowledge that they don't have access to, which is all about the child development bit. But when it comes to the food cooking, like modifying the ingredients, they are really good at that. Yes.
Yeah, I think it will be very great if you can share this knowledge to the even wider populations.
Yes.
Yeah. And someone was asking from Livia that other than internal organs, just now you mentioned internal organs is a good source of human proteins and ions. Are there any alternative food that can give the same nutrients? Would the iron from internal organs be the same from the iron from the spinach, bayam, etc.?
That's a good question. I think I'll pass it over to Prof.
Okay.
Prof.
Okay. I'll take this question. Okay, so they are what we call animal. The iron exists in the ferrous and ferric. Okay, in food. So in the animal form, animal protein, it is in the ferrous form, what we call heme. Okay, and in the plants, the spinach, it is in the ferric form, which is the non-heme. So in terms of bioavailability, meaning that the body, the intestines can absorb it, ferric definitely has to be converted to ferrous before it can be absorbed. Okay, so that is the bioavailability therefore reduces. Then secondly, in terms of plant proteins, yes, there are lots of plants like beans, lentils, dal that contain iron. But unfortunately, they also contain a phytate, which is what is known as anti-nutrient. All right. Now, the way the old people, you look at traditional cultures, actually, when we were young, we never had iron deficiency anemia, because I always look back into my culture. In fact, I was grappling with this problem, how to feed these children, because after they got all the 8 food groups, then we measured their iron, iron's still low, how? Then we realized that actually they are not getting an adequate iron from the non-liver food. And so when we added the liver in, then you see the iron started going up already, So what is in our younger days, we had no problems with eating liver. My mother would give us a liver, every month, once a month after your period. Okay, I'll buy the liver and then replace the iron that you have lost. So it was never a problem. But now the modern parents want to say, oh, liver is toxic lah, this blah blah blah. But how can the liver be toxic? The liver is an important internal organ in us. If our liver is toxic, I won't be talking to you. I'll be dead. I'll be encephalopathic. So there is no way the liver can be toxic. All right. The gut, yes, the intestines can be dirty. All right. They need to be cleaned properly. Yes, internal organs have to be cleaned properly. Like any other animal parts, they have to be cleaned properly. All right. But they are not toxic. Okay. It cannot be. Now, in the young days, we used to eat liver, no problem. In fact, it was nowadays, if you go to the market, the liver is given free. All right. But in our days, we have to buy liver. It was very expensive. All right. And We also get to eat kerang. I don't know how many of you, maybe you could ask your mother, eating kerang is like very normal. The kerang, when you cook it, you put it in your char kway teow or into your curry mee and 2 or 3 pieces, and that's enough already. Every day you eat this kerang, 3 or 4 pieces, you get your iron requirement. Actually, we only need 1 milligram of iron per day only, but because of the bioavailability, we need to eat more to get the 1 milligram, absorb 1 milligram, all right? So we actually get a lot of it is in animal food. In plant food, it is, like I said, the phytates. Now, in the old days, my mother or whoever cooks dal or beans, lentils, which are rich in iron, what we have to do is to soak it, all right? Soak it overnight. Now, that soaking overnight is a very important move. We also think that, soak it to soften it so that it's easier to cook. But actually it also fulfills another process, okay? It's the enzyme that is released, and this enzyme breaks down the phytate. Okay, once the phytate is broken down, the iron is now bioavailable, okay? So the old way of cooking is actually very, very kind of like wise way of so in the old days, iron deficiency anemia is not an issue. But nowadays, with the modern diet, we don't eat this. We only eat chicken 3 times a day. In those days, we were eating chicken once a year, once a year. So when we eat that once a year, we eat everything from head to toe. Everything is pun makan. Everything else we have to eat because food was expensive. But nowadays, this meat is cheap. So we are eating 3 times a day, which is not right. We shouldn't be eating chicken 3 times a day. We should be diversifying into plant proteins, into other things, so that our microbiome is more balanced, okay, for our immune system. So I hope it answers the person who asked that question about a toxic liver. It is not possible. Yes. You just ask the hepatologist. There is no way you can be alive if your liver is toxic. It's storing toxic things that it cannot be. In fact, it's full of nutrients because it has to process all these toxins. So the liver is really, really rich. It's in fact the real superfood. In fact, it's better than egg yolk. I used to think that egg is a superfood, but now I think the liver is the real superfood. But of course, as you grow up as an adult, we don't need to eat that kind of thing. But for a child, they need it. It's like, I always tell that seeing a child growing up is like looking at the house being built. Our body is our house. Our house is already built. So we are in the phase of maintenance and repair, which means that we don't need to eat a lot. Okay, we just need to eat enough to repair what is broken. That's all. But a child cannot. A child is growing. He is building his house. So during that stage of his building, he needs micronutrient. He needs macronutrients. It's like you build your house. You cannot just give bricks and bricks and more bricks. You need everything. You need the bricks, the cement, the roof tiles, everything, the windows, the metal things, and all that. You need everything. So does a child building up his body. He needs calcium, he needs iron, he needs zinc, he needs selenium to build different parts of his body. So we have to make sure that he gets his diversity, not from chicken 3 times a day. This is not diversity. This is very limited food choices. Right, so they have to eat maybe chicken in the morning and then fish, and then they get different nutrients from different food. There is no one food that supplies all the nutrients that a child needs. So you have to eat from a variety. Right, so that's why that diversity is important. Like I said, we see in our study children who eat 8 food groups every day. Then I look at them. Yeah, you are 97 centile for height, weight, and head circumference. My God. And they are not overweight and they are really active. So it does show that if we stop the biscuits and all that processed food, a child will naturally eat. They have a good appetite because they want to eat. They want to grow. But if they eat the wrong food, then they fill up the stomach with the wrong food. They cannot already. No place for the nutritious food. So it's premium space. A child's stomach is premium, is prime estate. You cannot fill it up with any junk food. You have to fill it up with nutritious food that will contribute to the child's brain and growth.
It's a really great awareness that you have raised.
Yeah. Okay.
Yeah, it's actually the projects that you had, and Generosity Gemilang is a great example of patients PPI based research. And I'm just wondering, like maybe Miss Rihanna, it's like based on previous experience, you are mainly working with like corporates on their CSR programs. So how do you think that this kind of experience is actually different as with corporates versus like with Prof. Lucy, like the academic teams and medical?
I think for corporate partners, most of them are funding arms, and we actually work. It will mean that we work on our own as in GG and corporate funders. The role the corporate partner plays is more funding, and we then report to them. So that's the kind of relationship that we're having, and sometimes we do, keep them posted on like our own programs. But if for Project Makan Sehat, it's interesting because it involves just not two parties. It's like multiple parties altogether. Include Yayasan Hasana is one of them. It's considered like the funding arm. And there's also others that help support in terms of providing resources like Prof's team, their expertise, as well as we had to bank a lot on community leaders and a fresh food supplier to get the job running. Whereas in our other programs, most of the running on ground things is done solely by us, our own staff and our volunteers. And it's just the corporate partner is just there to provide the funding or any advice if needed. But yeah, that's about it. So it's a very diverse project.
And I think, Rihanna, you didn't mention about the food, that we have another layer of economy that we are supporting.
Yeah,
the food. Yeah, maybe it's better it comes from you.
Yeah, so I think what we're also doing is with Grace Market, they also support even like the community, some of the community leaders that they source let's say the proteins or even things from the community themselves, and that's also another form of income that is generating into the community. Even like the farmers, for example, I know there are farmers providing surplus foods and they have to sometimes discard it, and that's where we provide the business for them. So again, all these little things we're then putting it back into the community, and it's like a cycle on its own. Yeah.
Very meaningful indeed.
Yes.
And yeah, maybe just one question for Prof. Lucy is that what do you think is the best contribution that you appreciate the most from the Generosity Gemilang or from the public NGO engagement in this research?
I think it is the coming together of like mindset. I mean, I was very, very amazed. I heard of a Generosity Gemilang before we met them, because we were also doing food distribution during to the Lembas Subang during that time. And but of course we were doing it as and when we had money and we had some donations, then we'll say, okay, we'll go in. And so finally when we met up with them, it was like, it is I think there were 3 of them came. Then I always remember, I said, these are 3 wise women who came to visit us. So they came, and we kind of like-minded people think to get the same, and then we kind of like synergize. So it is not just Generosity Gemilang, it is also the medical students. I must really mention the undergraduate medical students at Medical Society. They really came forward. We really need a lot of help because it's very intensive. We need to do the measurements that we need to do. And so Medical Society students were very enthusiastic. And if we call them at last minute, they will have 8 or so students lining up to volunteer. And then it's a collaboration with pediatricians as well, not just our department, but from Ministry of Health, because we need people to take blood from, and these are children who are screaming out in open, and you can't get them too distressed, because then the mothers will all run away. I don't want my blood taken. I don't want my child's blood to be taken. So we have to do it very skillfully in such a way that, they are not afraid. So all these coming together, I don't know how to describe it, but it was really wonderful. I think, Lysian, you have been to one of these sessions before. So yes, it is very chaotic, but in that chaos, it is quite very kind of lively kind of engagement of everybody coming together in a, with a good heart, meaning well-meaning. Yeah. So we hope to engage with this community, because it's not easy, because they are always very suspicious about researchers, taking blood, take our data, and but we have been giving them feedback. My RA, Dr. Ui Kaishan, he has been giving individual mothers, their report card. It's like their report card, okay? So this is where your child is height and weight is. This is where the centiles are. This is the growth, and then this is what your child has been eating, and this is your son's or your daughter's blood report. So it is that compiling it then for them to give them that feedback. Then I think that they really appreciate that, putting it together for them. Then how do we move forward? How can I improve? So we give them ways, not just like, okay, you're not doing well, you shouldn't be eating this and that, but we say that, you can do this and like that. So the support is important as well. So it needs a lot of people. It's not me alone. It cannot die.
I'm glad that to see the project is ongoing right now, like really well, even during this pandemic. I think we have covered all of the questions posted by the audience. Really, once again, I would like to say a big thank you to all our speakers for these sessions, Prof. Nick, Daliana just now, Prof. Lucy, and Miss Rihanna Yam for being here today. And I think we would like to also thank all our audience for attending today's sessions. I hope I'm sure you all have learned and enjoyed the presentations well. And very enlightening instead. So again, as a housekeeping note, please remember to record your attendance using the link attached in the chat box. And with that, we would like to conclude the webinar for today. So tomorrow morning, we will continue looking into child health, focusing on developmental disorders and obesities. And in the afternoon sessions, we'll be looking at NGO partnerships in research involving vulnerable populations and stroke rehabilitations, stroke rehabs. So yes, once again, thank you very much, and see you all tomorrow. Have a great evening. Thank you, Professor. Thank you, Rihanna.
Lucian.
Thank you.
Thank you.
Great evening ahead.
Yes, thank you.